virus, when you get it, it will weaken your immune system up to a level whereby the whole immune system is no longer strong enough to fight against diseases, and that's when diseases which you call opportunistic infections come in. So these diseases are quite a number of them, including things like cryptococcal meningitis, that is a fungal infection that affects the meninges or the coverings of the brain. So when people are having HIV that progresses to AIDS, they can actually get that as one of the opportunistic infections where they're going to come in with headaches, sometimes vomiting, and photophobia. They don't want to see light, or light makes them feel bad. There are quite a number of other medical conditions like tuberculosis. They usually come in handy in patients whose immune system has been brought down. These patients are going to come in with cough, weight loss, night sweats, and so many other symptoms are possible. There are even some malignancies or cancers that could come in simply because someone's immune system has been weakened by HIV, things like sarcoma and all that. So this virus, HIV, affects the whole system, like the whole body. It's a multi-systemic disease and it can affect any part of the body, and because of that effect, it could result in so many complications within our bodies.
Yes. So HIV is transmitted. We call it a vertical transmission and horizontal transmission. Yes. So give us a bit about that transmission.
So the vertical transmission is actually that transmission from the mother to the child. Okay, so you realize that HIV can be transmitted through that mean, and there are quite a number of people who are born with HIV, and the implicated mechanism is that vertical transmission, which could happen one during pregnancy when the mother is HIV positive. They could actually transmit this disease to their fetus, as well as during delivery. You understand that delivery is quite a difficult process. So many processes are involved. Sometimes we even have to assist some of these mothers to deliver. So through those means, there could be an exchange of blood that will result into the baby getting exposed to HIV, as well as during breastfeeding. That's why in some of the comprehensive packages that the Ministry of Health is giving out there is the prevention of mother-to-child transmission, as well as the elimination of mother-to-child transmission. Is that these comprehensive packages will contain a number of ingredients all aimed at preventing this vertical transmission from happening. However, we also have what you call the horizontal transmission, the one that is most common, that you viewers out here are mostly familiar with, whereby they're going to be a sexual encounter between someone who is HIV positive and another who is HIV negative. So the moment that happens and there's transmission of HIV, that will be called horizontal transmission. But of course, there are so many other mechanisms are possible, including the needle stick injuries. Some of us who are working in places like hospitals, maybe theaters, sometimes we're suturing our patients. So if a patient is HIV positive and by accident, the needle that you're using to stitch them gets to prick you or any stuff, they can actually get HIV just through that. Okay, much as they are not very common, but actually they are possible. Even things like blood transfusion, luckily these days so much technology has come up and most of the blood products are safe. However, back in the days when we didn't have a lot of technology, sometimes it was possible to transmit this disease through things like vertical transmission. Things like blood splashes could happen and accidents whereby there could be exchange of blood. So all these constitute what you call horizontal transmission of HIV.
Okay, so HIV can be transmitted in a number of ways. So now, Dr. Alex, now that bring us now, let's go right to the topic. So what is pre-exposure prophylaxis and what is post-exposure prophylaxis exactly?
Thank you so much, Dr. Kamala. Greetings to our dear viewers, and thank you so much for tuning in. This topic is very sensitive, pre-exposure prophylaxis and post-exposure prophylaxis. I'm a youth, and it's my pleasure being here to talk to my fellow youth because they are the people that are actually most affected by HIV. And most of the times, we don't know how intense this issue is. You've talked about 1,000 people getting HIV every week. So if we have 1,000 people getting HIV every week, that means that we have in Uganda.
That's a big number.
That means that around 52,000 people get HIV every year because a year has 52 weeks. So if I have 1,000 per week, that means there are 52,000 per year. And we have close to 17,000 deaths every year, either directly or indirectly caused by HIV. So it shows that most people out there are dying of HIV, acquiring HIV, and despite the fact that the ministry is doing strides to enroll them to care, to ensure that we attain the 95 UNAIDS code, there is a need to prevent the transmission. So it's my pleasure to be here to talk about this very, very important topic of pre-exposure and post-exposure prophylaxis.
Maybe Dr. Alex, actually, about the statistics you mentioned, statistics service that currently worldwide, HIV has killed close to 50 million people. So you can imagine our population.
The whole population of Uganda,
yes,
actually.
HIV has claimed all that population. So you can imagine.
Meaning that it's going well. But ideally, it's much more in sub-Saharan Africa, whereby Uganda is one of them. And that means that strides should be really very intense to ensure that we curb this HIV and AIDS by 2030, as UNAIDS is looking up to having the 95 code attained. So we're having around 5.4% of our population living with HIV, in that every 100 people that you find, close to 5.5 people have HIV. So that's a very, very, very big number. Of course, you find 100 people every day at least, and that around 5 of them are living with HIV. So that's a big number. People are getting HIV, people are dying of HIV. So we need to intervene and see how best we can prevent. Back to pre-exposure prophylaxis and post-exposure prophylaxis. These are interventions that were developed to prevent people from acquiring HIV. As you hear the word pre-exposure, it is happening before exposure. I'm giving someone, I'm developing an intervention that is preventing someone from getting HIV before they actually get exposed. However, I'm looking at this person who is at risk of exposures. Let me give an example. We have some populations that we have populations that are always at risk of getting HIV. For example, we have sex workers, people that sell their bodies to earn a living. Those are people that are at risk of getting HIV. We have people like armed forces, you know. We have people like these truck drivers. They can be having a wife every station. Kisumu, they have a wife. Chisenyi, they have a wife. At the point where they pack the things from the truck, he has a wife. So you're looking at each of these points as potential points of getting HIV. So there are those populations that are really, really, really at risk. So despite the fact that they are going to be having this kind of activity that puts them at exposure, at frequent exposure, even before they are getting exposed, we are giving them these medications, which they take every day to prevent exposures.
Yes, we also have, remember, we also have a significant population of young people that were born with HIV, and they are now of marriageable age. They are dating, they are seeing people, they get into
The discordant
partnerships.
relationships.
Yes, we call them discordant relationships, where someone is HIV positive and their partner is HIV negative. So there are also a significant number of those around, and the partner that's HIV negative may want to protect themselves from getting HIV.
So we shall give them pre-exposure prophylaxis. They're going in a marriage where they're going to be constantly exposed.
Yes.
So I want to give them pre-exposure prophylaxis. Then for post-exposure prophylaxis, an exposure has happened. Dr. Ssekyanzi has talked about the different mechanisms in which we get exposed, or the different ways in which you get exposed. So you get that exposure, and we are giving you these medications so that you don't get the HIV. But the exposure has already happened. Yes. So that's the post-exposure prophylaxis.
Okay, yes. Thank you, Dr. Alex. So Dr. Alex has just helped us to distinguish between PEP, post-exposure prophylaxis, and PrEP, pre-exposure prophylaxis. So we are going to take a small break and we'll be back.
This message is from the Ministry of Health with support from partners.
Since 2015, Quiz Mali Production has been at the forefront of media innovation. Our passion for storytelling and creativity has driven us to deliver over 100 successful projects, making a lasting impact on the industry. With 4 highly acclaimed TV shows, we've become a household name, bringing quality content to your screens. At Quiz Mali Production, we specialize in content creation, digital media marketing, media buying, and documentaries. We plan corporate events, provide top-notch photography and videography services, and offer seamless translations and live streams for your every need. Join the hundreds of satisfied clients who trust us to bring their visions to life. Quiz Mali Production, your partner in media excellence. Visit us at Quiz Mali and let's create something amazing together.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Good evening and welcome back to the DOCtalk Show. My name is Dr. Kamala and thank you so much for joining us. So this show is sponsored by the Ministry of Health and Kamala Men's Collection. Before we went for a break, we were talking about PEP, post-exposure prophylaxis, and PrEP, pre-exposure prophylaxis. So we are going to look at the process of this PEP and PrEP. So who is eligible for PrEP? How do they get it? Are there side effects? So Dr. Alex is going to take us through this. Dr. Henry and Dr. Alex are going to take us through this.
I request to begin by thanking the Minister of Health of Uganda. One, despite the fact that they are our sponsors for this show, but they're also doing strides to ensure that HIV is curbed in the communities. We've had an improvement in access to services. We've had an increment in the number of health workers that are trained to provide comprehensive treatment, diagnosis, treatment, screening, support to people living with HIV, and as well to provide support to people that are negative, that are HIV negative, so that they don't contract the disease. So the ministry is doing a lot of strides to ensure that the disease is really curbed, and one of them is sponsoring such shows. So the process of initiating post-exposure prophylaxis, as we say that someone has had the exposure. So if you've had the exposure, one, we want to look at that exposure. We want to assess you and look at the exposure and how it has been. Because there are times that people come with fears, if because of the stigma, because of lack of information. I'll just give an example. If someone has had exposure to saliva from a person living with HIV, they'll think that maybe this is a potential, kind of fluid that can cause me HIV. So they will run to a health facility to seek post-exposure prophylaxis services. Maybe if someone has gotten exposure to tears, which we very well know that if they are not blood stained, they cannot transmit HIV. So usually these patients, we first assess them to find out how the exposure has been, and we also want to look at the future, what the future holds for them. For example, if I have an uncle who rapes maybe a relative or a child, you want to look at this child. How best are you going to support them so that they don't get the exposures? Because you can give them PEP for 28 days. They run through the cycle of post-exposure prophylaxis, but again they are going to be exposed. So you want to really assess the person. And there are things that as well we do immediately. A patient comes and they have had this exposure. One, there are things that we want to look at. For example, we want to prevent unintended pregnancies. For example, someone has been raped, someone has been defiled. You don't want this person to end up with unintended pregnancy, that probably they will not love the child, probably they don't have support to take care of the child. So you want to give emergency contraceptives so that they don't end up with unintended pregnancies. You want to screen for the other sexually transmitted infections and see how best you can prevent them. Chlamydia, gonorrhea, bacterial vaginosis now has been proven to be sexually transmitted. So you want to see how best you can prevent all these other sexually transmitted infections in this person. You want to link this person to support. For example, if it's a rape case, if it's a defilement case, if it's a forceful sexual, assault, you want to link this person to police if they want to take legal action. You want to link them to police so that maybe you collect samples from this person that can be used in legal processes. So clinical assessment, one, determines the extent of the exposure. Is there really a risk or there is no risk? And as well, link this person, provide other services that are preventional, because you want to prevent something before it's happening. And as well, somewhere try to link. But as well, we want also to give this person first aid. For example, if someone has had a splash of blood, you want to wash the area that has been affected. In case this person has had maybe a needle prick, you want to also wash around the area that has been affected with clean water. We usually don't want to use those soap, those corrosive agents. Some people use acids so that jig, to ensure that they remove the HIV. But we just want to wash the area. So all that is part of first aid. So after that, we also determine the eligibility for PEP. Is this person eligible to take PEP or not? Because we want to do targeted, kind of service delivery. If someone is not eligible for PEP, then there's no reason as to why we're giving them PEP. Usually we do HIV testing and screening for people that have had that exposure. And we want to give PEP services to someone who is HIV negative. If you're HIV positive already, there's no need as to why we give you post-exposure prophylaxis. You're already infected with HIV. And also we want to usually initiate post-exposure prophylaxis in the first 72 hours of exposure. Usually what happens is that when we say 72 hours, people wait for the 65th hour, for up to 70 hours, and then they seek care. The earlier the exposure, the earlier you start post-exposure prophylaxis after exposure, usually the better. If you get exposure today, you just run to the facility there and then so that you access PEP services. You don't need to wait for time to first elapse up to like 70 hours and then you rush to the facility. You need to seek PEP services immediately. Because post-exposure prophylaxis, usually what HIV does to affect our immune system, it gets its genetic material and puts it in our genetic material, in our DNA, and then it spreads it all over the entire body. So we want to capture this process before it comes to completion. Usually people come maybe 6 days and you wonder, like 6 days, probably the process is already done. The HIV has already moved to the different parts and it's going to now develop into an infection, and there is literally nothing much that you can do about it. And then always give PEP to people that have exposures, either when the person is a known HIV positive person, the person that has exposed this person, the person that has exposed this person, this patient that I'm having. This patient, if the person that has exposed this patient is either HIV positive or is of unknown HIV status. Because if I'm known HIV positive, then there is a risk of infection. If I'm of unknown HIV status, I can be HIV positive, I can be HIV negative. One day I had a patient a female patient, he had gone for a weekend marriage in one of the suburbs around Kampala. So as he was doing those kind of housework to prove that she's a wife material, that's when she landed on a teen that had some names that she couldn't understand. So she rushed to Google and searched, hey, what's this? What's DOCtalk? What's this? And found out that these were actually HIV medications. Meaning that this person was not storing these medications for maybe his uncle or aunties or siblings. It's this person that was taking the HIV medications. So that clearly shows you that this person is HIV positive. So immediately you know that the person is HIV positive. Or if you don't know the exposure, but you've been exposed, you don't know the status of the person that has exposed you, but you've been exposed, you should actually be rushing to a health facility to start your post-exposure prophylaxis. And there are other things that we want to do for this person, most especially if it comes to initiation of post-exposure prophylaxis, and that's counseling and support. You want to support this person because usually post-exposure prophylaxis, we give these medications for 28 days, and those are 4 weeks, close to 1 month. So you want to be sure that this person is going to take these medicines up to the end of the 28 days. You can give these medications, someone takes today, tomorrow they miss, the other day they don't take. So you want to ensure that you counsel them and support them. Counseling also comes in because you need to tell someone the process. What process are we going to go to? The other tests that we do after we have given post-exposure prophylaxis, and we usually do tests to find out whether this person actually converted, because at times you can give the post-exposure prophylaxis, but maybe this person came late or didn't adhere very well, and this post-exposure prophylaxis is not working out. So if it's not working out, this person is going to seroconvert from being HIV negative to being HIV positive. So there are those tests that we do. There are routine tests that we always do. So we do the test at 1 month, that is at the end of the 28 days. We do the test at 3 months, and then a test at 6 months. So after those routine 3 tests, that's when we declare someone HIV negative. And if they seroconvert at any of those points, we declare them HIV positive, but we think that the exposure was because of what caused them to be HIV positive was because of the exposure that they had. So usually if someone turns out HIV negative as well in the counseling process, we want to prevent the recurrent exposures so that people don't get recurrent exposures. That exposure that they have gotten should be the very last exposure. And then in that follow-up, of course, we link them to care. If you find that they're HIV positive, they have the HIV, you should link them to ART so that they start their process of getting lifelong antiretroviral therapy.
Okay, so that's the process of getting PEP,
post-exposure prophylaxis.
Post-exposure
Yes.
prophylaxis. So post-exposure prophylaxis is for you if you've had an accidental exposure, you're HIV negative, and then you have an accidental exposure to HIV. Either maybe you're a health worker and you've come into contact with some infected body fluids, or you've had a forceful sexual encounter with someone, or sometimes they're not accidental, unfortunately. Some people practice maybe unsafe sexual practices and they end up exposed. So we are going to take a short break and then we'll come back and talk about the process of PrEP, this time pre-exposure prophylaxis. Thank you and stay tuned.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Hello and welcome back to the DOCtalk Show. My name is Dr. Kamala Ivan. Thank you for joining us. This show is sponsored by the Ministry of Health and Kamala Men's Collection. So on today's episode, we've been talking about post-exposure prophylaxis and pre-exposure prophylaxis, which are great tools in the prevention of HIV transmission. And before we went for the break, we had talked about PEP, and now we are going to talk about PrEP, that is pre-exposure prophylaxis. So Dr. Henry, take us through the process of pre-exposure prophylaxis. How do I know that I need pre-exposure prophylaxis? Who is eligible? And what are the side effects? How do I get it? And does it really prevent me from getting HIV?
Okay, thank you very much, Dr. Kamara. And maybe before I even go to the PrEP, which is pre-exposure prophylaxis, the treatment that we use for patients who have repeated exposures to HIV and you want to prevent them from getting this disease. So I want to talk a little bit about counseling, one of the most neglected part of this process, that patients always need counseling. Even before we get to the PEP or PrEP, many patients usually come to us doctors and they need this routine counseling for HIV. Sometimes couples walk into a clinic and they want to test their HIV status, and many times they don't get the appropriate counseling, which I believe it's something that we need to work on as health workers. We need to always counsel people, because if people are coming for such a test, either result is possible. They could come out negative, they could come out positive. Negative result is always a good news that people will celebrate and they walk out of your clinic happily. But usually if the result is positive, the kind of emotion that comes along with it, sometimes it needs a bit of good handling, in that if you don't handle the situation very well, many people could actually get very, very dire consequences. So I want to call upon all health workers out there that if people come to you for counseling, for HIV testing, please give them as much counseling as possible. Tell them that the possibility of result turning out positive is there and they should be prepared for it, and there are so many things which can be done, like they can be linked to care and they can live life normally just like any other normal person. So the same applies to these patients who are on PrEP, like I earlier on mentioned. The people who are on PrEP or people who can be given PrEP are those people who have repeated exposures to HIV. This include people like sex workers who at any time they could get a client that is HIV positive and they could spread HIV to them. People who have multiple sexual partners, especially the truck drivers, like Dr. Alex mentioned, we've had reports that these truck drivers they will be having almost a wife at every station. So this means that they have actually multiple sex partners, and any other kind of category. As long as they have multiple sex partners, the risk of transmission of HIV is quite high. We've also had reports that people in the armed forces they tend also to have quite a number of sex partners, especially if they are usually on a move. So whenever they go to a country or maybe they go to any other place, they tend to get partners there. So such people, they need to be protected in a way. Much as yes, we encourage abstinence, we encourage being faithful, we encourage them to use barrier methods like condoms. Sometimes these are not effective, and they need to be protected from getting HIV. So PrEP is the medication that we give them to prevent them from contracting HIV. It's actually an HIV medication, but this one is well suited to ensure that somebody will be protected. But putting that aside, there are also quite a number of interventions that are put to prevent the vertical transmission. You must have heard about EMCT, which means elimination of mother-to-child transmission. So that's one of the interventions that the Ministry of Health has put across to ensure that mothers who are HIV positive they don't pass on the HIV to their children. So things like ensuring that mothers attend antenatal care where they will be screened for HIV, ensuring that mothers deliver from hospitals where healthcare workers can take good care of them, ensuring that mothers take their HIV medication so that they don't have very high viral loads that they can spread to their children. Ensuring that they have safe breastfeeding practices. Realize that patients who have HIV and they're breastfeeding their children, there's a recommended way they should do it. One of the things that has come across is that about the exclusive breastfeeding, at least for the first 6 months. At some point back in the days, there were quotations whether people should breastfeed or not, but according to most of the recent research, it seems breastfeeding actually has many benefits because not breastfeeding the children predispose them to malnutrition and it could put them at risk. Then there's also
provided it's exclusive.
Yes, it has to be very exclusive because if it's not, it puts the baby at risk. If the breastfeeding is not exclusive, today you breastfeed the baby, tomorrow you give them something else, you could actually increase their risk because whatever you're feeding them could damage maybe their oral mucosa and then it puts them at an increased risk
of getting HIV. Yes.
Yes. So another population that I would like to mention that may be eligible for PrEP, that is the pre-exposure prophylaxis, are the people who were born with HIV. As you know, we have a significant population of those in Uganda. So someone was born with HIV and they've been living with HIV, they've been healthy, they've been looking after themselves, and now they are of the age where maybe they want a partner. So some of them may get a partner who is HIV negative. So that HIV negative partner can take PrEP in order to prevent themselves from getting HIV. Of course, with the knowledge of the HIV positive partner, it's something that the two enter in together. Yes, so I've seen a number of young people discussing this as well because we have a lot of young people who were born with HIV and they're living with HIV positively. They've looked after themselves, they're healthy, they have a positive attitude to their status, they're looking after themselves, and then they get a HIV negative partner, and that partner can take pre-exposure prophylaxis. So, like we've said, pre-exposure prophylaxis is for the people who are going to who are going to live lives where they are continuously exposed to HIV. So Dr. Alex will take us through more about the pre-exposure prophylaxis. So we've already seen who is eligible for this. Now, how do they, how is it done? What should someone expect? And this is medication that you're going to take for a long time. So are there side effects? Someone may be wondering, are there side effects to this medication? And if I'm taking this medication, for instance, do I still have to use other protection? For example, do I still have to use a condom? Do I still have to use other methods of protection? So Dr. Alex can take us through that.
Thank you so much for that question. One of the before we even go to that, one of the populations that we actually not talked about exclusively, yet they are very, very much at risk, are the fishermen. We know that Kalangala is one of the districts that are highly affected by HIV. So you find that they always have a saying that the money that I work, or the money that I earn on a particular day, I should spend it that very day, so that tomorrow I look for more money, or I look for money afresh. So imagine if maybe this fishermonger gets like 2 million in one day, and this fishermonger is looking for all ways of clearing this money out. Most of the times they end up having as many sexual partners as possible in even that one day. So that population is also very, very critical. And of course, Ministry of Health is coming up with different interventions to ensure that, one, they break the myths and misconceptions about PEP and PrEP, but especially pre-exposure prophylaxis in such a population, so that these people can also get these services and prevent those skyrocketing cases of HIV in those areas of Kalangala. And then we talked about post-exposure prophylaxis. Usually when you're exposed and we give you this post-exposure prophylaxis, you've been exposed, there was a risk of infection. Usually we say that if someone takes 3 episodes of PEP, post-exposure prophylaxis, within a calendar year, we always want to initiate you with pre-exposure prophylaxis, because your exposures are too many.
Yes.
We're just wondering that one time you may actually end up getting HIV. So we want to initiate you to this continuous kind of care of pre-exposure prophylaxis. So if you take PrEP more than 3 times, because most of the times the challenge that we health workers get, these patients at times don't open up to us. They come to my facility today, they tell me that, hey, this is my first exposure, but actually when it's the second, when they get another exposure and they go to a different facility, they'll tell this person, this health worker, that this is my first exposure, but when it's actually the third. So when you have more than 3, or if you have 3, the next time, we don't really initiate you on post-exposure prophylaxis. We want to give you pre-exposure prophylaxis, because your exposure the frequency of exposure is too much.
Okay, so let me get this. So if you've had to take post-exposure prophylaxis 3 or more times in a year, it means that you are constantly exposed. You're constantly at the risk of acquiring HIV. And so it is much better for you to take pre-exposure prophylaxis. That is, you take medication daily. Is it on a daily basis?
Yes.
To prevent you from acquiring HIV. Okay, so we are going to take a short break. And when we come back, we'll continue with the pre-exposure prophylaxis, and then we'll also look at the different ways in which people do pre-exposure prophylaxis, because there are different ways. Medication isn't the only way. So stay tuned, and thank you for joining us. We'll be back.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Crafted with precision, designed for brilliance, Supreme Wave pens reach the hands that shape tomorrow. Only a Supreme Wave delivers expression this pure. In every stroke, confidence flows. Because greatness isn't guessed, it's written. Supreme Wave, write your future.
Supreme Wave are the best.
Agriculture is Uganda's economic backbone, employing about 70% of the working population and contributing 20% of the GDP. As the world becomes a digital global village, ICT has proven to increase productivity in the agricultural value chain. UKUSAF, through its Strategic Plan 3, recognizes the importance of access and usage of ICT-based tools, information and knowledge for farmers by providing them the needed skills to live, learn, work and participate in a digital society.
We came up with a project which we took to UKSAF, and we're happy that UKSAF supported it. That project is called ICT for Farmers. What did we get from ICT for Farmers? We managed to skill up to 100,000 farmers.
You are watching The DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back to the DOCtalk Show. My name is Dr. Kamala Ivan. Thank you for joining us. And in today's episode, we are talking about pre-exposure prophylaxis and post-exposure prophylaxis, which are very vital tools in the prevention of HIV transmission. This show is sponsored by the Ministry of Health and Kamala Men's Collection. And with me here today, I have Dr. Henry and Dr. Alex to help us break down and understand this topic. So, Dr. Alex, tell us more about the different methods that we use in the pre-exposure prophylaxis of HIV.
The methods that we use in pre-exposure prophylaxis, there are basically three that are current, but more advancement are going on, more research is happening so that we get other extremely infectious interventions for preventing transmission of HIV. There's one for drugs where you swallow a tablet every day, where you take these medications that are that are meant to prevent someone from getting HIV. You swallow a tab every day as long as you still have the exposure. So after you've had the exposure, or if you reach a situation where you're now living this kind of situation that was putting you at frequent exposures, then at such a time, this person can actually stop taking these tablets, so these medications that are meant to prevent them from getting HIV. Some of them is just taking tablets, or what we call medications, antiretroviral therapy. The next one is, or the other one that we have is the use of a depivirine ring. So this ring is a ring that is inserted in the vaginal canal, way up in the vaginal canal. It's made up of silicone, but that silicone has that component called the depivirine. So this is also an art medication. However, for it works locally. It's not like a tab that I will take it and then it is absorbed into my system so that it fights the infection. For it, it is at that point where, for example, I'm looking at a sex worker. It's at that point, or at the point where the risk of getting the HIV is, and that's the birth canal. So meaning that this depivirine ring prevents infection at that point. So usually when I have a different kind of exposure that puts me at risk, then I'm eligible for post-exposure prophylaxis because I've had an exposure that is different from the one that I'm preventing. This one is preventing only exposures due to coming as a result of sexual intercourse. So this ring is changed every month. So it's a ring that you put, someone can be trained to insert it, and then you can visit a health worker to help you insert it if you're not comfortable or if you're not conversant with how it is inserted. So it is inserted, stays in situ for 1 month, after which it is changed. And then the other mechanism that we always use is the injectables. There is a drug called cabotegravir, which works for 3 months. It gives you that protection for a period of 3 months. This drug was launched in Uganda, though it has not yet been distributed in these most of the health facilities, but it was launched, and I'm sure the ministry is doing all that is possible to ensure that these facilities, at even the lowest facilities, local health facilities, health center 3s, also have these long-acting injectable cabotegravir. So this is an injection that you get once a month. The reason as to why all these interventions are coming in, because this was just recently, inaugurated, to ensure that if those people that face stigma because of these tablets can actually visit a facility once in 3 months. Once the quarter of a year, you go to a facility, get this injection, it gives you this protection against HIV over a period of 3 months. Because one of the challenges that we are facing is stigma. If someone sees you taking a tab every day, they're thinking that maybe this person is actually HIV positive, but rather this person is preventing themselves from getting HIV. So those are the 3 methods that we use for pre-exposure prophylaxis. It's a bit different from post-exposure prophylaxis because we said in post-exposure, I will take the tablet for only 28 days or 4 weeks. And then for pre-exposure, I take the tablet as long as I still get the exposure. So when I finish getting the exposure, then that's the time that they stop taking these medications. You talked about side effects. These drugs, it's they cause side effect like any other drug, but the side effects of these medications are medications that are manageable. There are side effects that are manageable, especially if reported early, and their side effects are not very, very severe. These are side effects that are very, very rare, that happens in very, very rare situations. And health workers always assess you to find your eligibility. There are people that take these drugs and develop reactions, you know, as you see that our bodies are different. Some people can get an injection and they react over it. So someone can swallow a tab of maybe, you know, and they react over it, but it's a very, very rare situation. And usually when we have people developing immense reactions against these medications, especially pre-exposure prophylaxis, at times we change the medication from one medication to another, which does not bring side effects that are similar to those that this person has gotten while taking this drug. So the side effects are very, very minimal. They are really, they are not worrying side effects, and they are manageable side effects. Yes.
Okay. So so we have looked at pre-exposure prophylaxis, how it's done, and the side effects being minimal. So it is quite safe for someone to take over a long period of time. So also you've looked at the different methods of pre-exposure prophylaxis. So as we wind up, we are going to look at some of the challenges when it comes to pre-exposure prophylaxis. What are some of the challenges, Dr. Henry or Dr. Alex? What are some of the challenges with this method of prevention of HIV transmission?
Thank you very much. Before I even go to the challenges, Dr. Alex has mentioned about carbotilgrava, which is an injectable way of preventing spread. And from the time that the drug was discovered, research showed that actually somebody could take it once in 3 months and they are safe. There was so much jubilation all over the world. And I feel like it's something that's helpful. Imagine you're just taking this one injection and it's going to keep you safe for all the 3 months. So, and we hope other better
Interventions are coming.
Because
Sure.
as time goes on, we know it's always improving in everything.
Is it available here in Uganda?
It was launched, and I'm sure it's going to be available soon. Even in the lowest health center threes, it's going to be available. You know, facilities or points of care where they provide HIV prevention and treatment services.
An injection that you take once
Once
in 3 months,
3 months, yes.
and it protects you against HIV. Yes.
Now, talking about the challenges, and there are quite a number of them. One of them being the stigma. There's so much stigma associated with HIV. People there's too much that there's so many myths, misconceptions, as well as too much stigma about HIV. And this, of course, affects the way people, seek care, how they seek treatment, their treatment adherence, and all that. So we really have to come up with a way of reducing this stigma. Even if somebody is HIV positive, they deserve the love that we will give any other person. They should be loved the same way. I mean, even if they shouldn't be treated as if they're alien from us. So people who are HIV positive, we need to treat them with love, with care, just like we treat any other normal persons. Two,
and we shouldn't pinpoint them as they're taking these drugs, because like I said, you're taking a tab every other day. Every day, not every other day. You're taking a tab every day. So I'm imagining if someone sees you taking a tab every day, what their mind will perceive. They will be thinking like, hey, this person is already HIV positive. But when they're actually trying to prevent.
Yes. And besides, I feel like HIV has reached a point whereby people should actually be free to talk about it. Somebody should be free to say, yeah, I'm HIV positive, and this is my tab that I take every day, and it should be normal. We're still at that level whereby people are fearing so much, they're hiding a lot, and that's affecting disclosure. We realize that there are couples out there whereby one of the partners is HIV positive, but they can't even disclose their partner. In a way, they put them at risk. Okay, they put their children at risk, and all these things should be worked out. So we need to come up with ways of reducing stigma, and we cater for HIV patients just like we cater for any other persons. On top of that, there's quite a bit of knowledge gap. There's quite a lot of information that's not known out there. People don't know that when you get these exposures, there's actually something that can be done sure that somebody doesn't develop HIV and that can progress into AIDS. So
Most of the times they just take the emergency contraceptives because at times they have had it from a friend or so they take just the emergency contraceptive against the unintended pregnancy and they leave out the HIV preventive modalities.
And also some of these medicines are not yet widely available in all places. You realize that actually accessing some of these medicines can be a challenge to some people. So so things like access to the medication, stigma, and then the information gap, plus much more. But luckily, the Ministry of Health is doing quite an immense job. They are trying to ensure that these services are available right at the lower health centers, district hospitals. So we call upon our people out there that should you get an exposure, okay, or should you be at a risk at any time, it's quite important that you seek out the services that will be suitable for you. And after you've gotten the services, please adhere to the treatment, take the medication as been advised, go for these checkups, for instance, like the doctor mentioned, that after 1 month of taking the treatment, you need to go and be checked. Then after 3 months, as well as 6 months. So with all this, you can actually get that exposure, yes, but like normally, just like any other person who does it.
Yes, so the stigma is an important one. It reminded me back to the other population I talked about of people who are born HIV positive. Many times there's so much stigma that they don't even want to disclose their status, and yet they are healthy otherwise and doing well. Yes, so we've had quite a lengthy discussion on PEP and PrEP, post-exposure prophylaxis and pre-exposure prophylaxis, and I hope that you've learned something and learned the difference between the two. So post-exposure prophylaxis is for you if you're HIV negative and you've had an accidental exposure to HIV or just an exposure to HIV that was not intended. You can take medication and stop yourself from getting HIV. Pre-exposure prophylaxis is for you if you live in a situation where you are continuously exposed to HIV, you are at risk continuously. So you can take medication and prevent yourself from getting HIV. So we are going to take parting shots to wind up the show. I'll start with Dr. Henry. What's your parting shot?
Well, thank you very much, Dr. Kamala. It has been a great show. Hope our viewers out there learned something. Just encourage you to keep safe and know where to get the information, where to get the services, and whatever you do, keep safe, be healthy, because it's health bodies that will make our money. Thank you very much, and I wish you a good time.
Thank you. And Dr. Alex, your parting shot?
Thank you, our viewers, for keeping up to the talk show up to this time. Just a parting shot, HIV is here with us. The best thing that you can do for yourself is to prevent yourself from getting it. Thank you.
Yes, I think that's a very good take-home message for us. HIV is here with us, but it is preventable, and you should do everything to make sure you do not catch the virus. So my name is Dr. Kamala Ivan. I've been your host today. Thank you for tuning in to the DOCtalk show. Thank you for joining us. Keep joining us every Thursday at 9 p.m. and have a good evening.
This message is from the Ministry of Health with support from partners.
UBC, inspiring Uganda.
Hi, thank you for coming.
Thank you.
Oh, just a second. Where is your tax clearance certificate?
Hey.
You don't seem to have a tax clearance certificate, do you?
Oh no, I haven't filed my returns.
Sorry, we can't proceed without it. Can we bring in another bidder now?
Next.
Opportunities don't wait. Avoid penalties and interest by filing and paying your taxes before June 30th, 2025. Call our toll-free number or WhatsApp for help.
Uganda Revenue Authority, developing Uganda together.
I'm Dr. Julian Kamala, a doctor in agriculture and rural transformation. You are most welcome, UBC, at Delight to Know Your Business, where we have a model, a dairies model, we learn by doing. Principle number 5 of Move 7 Economics says market integration. We have done it.